So today we are going to study the ischemic heart disease and its manifestations. So the first topic is the angina. Angina is a chest pain that is due to ischemic myocardium, which is secondary to the coronary artery narrowing or spasm. There is no necrosis of the myocardial tissue. The angina is divided into three types: the stable angina, the vasospastic angina, and the unstable angina. So the stable angina is the most common type, and it is usually secondary to the atherosclerosis. There is more than 70% blockage of the coronary arteries, most commonly left coronary artery. The typical symptoms include the exertional chest pain in the classic distribution, that is the left shoulder, left chest area, and the jaw area. There is usually a depression on the ECG that is resolved with rest or nitroglycerin. Then we have the vasospastic angina, also known as mental angina or the variant angina. It occurs at rest secondary to the coronary artery spasm. Remember that there is no coronary vascular occlusion in the vasospastic angina. However, the coronary arteries produce a transient spasm which causes blockage in the blood flow to the heart, causing angina. There is transient ST elevation in the ECG. The tobacco is the well-known risk factor. However, other risk factors include cocaine, alcohol, and traptans. It, it is usually treated with calcium channel blockers, but nitrates and smoking cessation can be useful as well. Then we have the unstable angina, that is also known as the progressive angina. It is due to thrombosis with incomplete coronary artery occlusion. Usually there is more than 90% occlusion. The coronary stream syndrome is industrial coronary stenosis. Vessels are maximally dilated at the baseline, and administration of vasodilators such as diphenhydramine dilates normal vessels. This causes shunting of blood toward the well-perfused area, and the already ischemic area in the myocardium is further deprived of the blood. The principle behind pharmacological stress test with coronary vasodilators is basically the coronary stream syndrome. Then there is sudden cardiac death. That is, the death occurs within 1 hour of symptoms. It is most commonly due to lethal arrhythmias such as ventricular fibrillation. It is associated with coronary artery syndrome in more than 70% of the cases. However, cardiomyopathy such as hypertrophic or dilated cardiomyopathy and hereditary ion channelopathies such as long QT syndrome, Bermuda syndrome are also well-known risk factors of a sudden cardiac death. It can be prevented with the enterocardiac defibrillators. Then we have the chronic ischemic heart disease, that is the progressive onset of heart failure for many years due to chronic ischemic myocardial damage. So the concept of myocardial hibernation and myocardial stunning. So myocardial hibernation is a potentially reversible LV systolic dysfunction. It is the left ventricular systolic dysfunction in the setting of chronic ischemia, and when there is adequate oxygenation, the myocardium can return to its normal activity. In contrast with myocardial stunning, it is a transient LV systolic dysfunction that is after a period of acute ischemia. Then we have the myocardial infarction. Myocardial infarction is most often due to rupture of the coronary artery atherosclerotic plate, that is the unstable angina. So when there is unstable angina, that is most likely due to thrombosis of the coronary arteries. When more than 90% of blockage has occurred, it results in insufficient blood supply to the heart. It causes ischemia of the heart and increase in cardiac biomarkers such as CK, MB, and troponins. So there are two types of myocardial infarction. One of them is the non-ST segment elevation, and then there is ST segment elevation MI, so also known as NSTMI and STMI. So the NSTMI is due to subendocardial infarction. So NSTMI, since endocardium is the least perfused area, it is the first area that is to be affected when the heart is underperfused. So the subendocardium, that is another one third, especially vulnerable to ischemia, and there is ST depression on ECG. However, in STMI, it is due to transmural infarction. There is full thickness myocardium involved, and there is ST elevation, and eventually there is development of pathology Q waves on the ECG. Then we have the evolution of the myocardial infarction, that is the changes that occur in the heart muscle after a period of time in myocardial infarction. So the commonly occluded coronary arteries are the left ventral descending artery, then we have the right coronary artery, and then last we have the circumflex artery. The symptoms of myocardial infarction include diaphoresis, that is excessive sweating, nausea, vomiting, severe retrosternal chest pain, that is epigastric chest pain, then the pain in the left arm or pain in the left jaw, shortness of breath, and fatigue. So the changes that occur in 0 to 24 hours are there is gross dark mottling and pale with trazodium stain. However, on light microscope during the early hours, that is the 0 to 4 hour period, there are wavy fibers with early coagulative necrosis. In the 4 to 24-hour period, the cell content is released into the blood, edema, hemorrhage. There is the increased risk of reperfusion injury, that is the free radicals, and increased calcium influx, which can result in hypercontraction of the myofibrils, and there is dark eosinophilic strips. The complications, early complications include the ventricular arrhythmia, heart failure, and cardiogenic shock. Then after 1 to 3 days, there is hyperemia on the gross findings. However, there is extensive coagulative necrosis, and the tissue surrounding the infarction shows acute inflammation, neutrophils. There is post-infarction fibrous pericarditis. Then after 3 to 14 days, there is development of hyperemic border with central yellow-brown softening, and there is infiltration of the macrophages. After macrophages, they cause the formation of granulation tissue at the margins. The risk factors in this period include the free wall rupture, which can result in tamponade. There is pectoral muscle rupture, which can result in mitral regurgitation. Then 2 weeks to several months, there is complete scar contraction, and the heart is at increased risk of developing Dressler syndrome. Other complications include heart failure, arrhythmias, and true ventricular aneurysm. So the diagnosis of myocardial infarction in the first 6 hours, ECG is considered as the gold standard. However, cardiac troponin I rises after 4 hours, and it is at peak at 24 hours, and it continues to increase at 7 to 10 days, more specific than the other protein markers. Then we have the CKMB that rises after 6 to 12 hours. It peaks at 16 to 24 hours, just like the cardiac drop I, but it is predominantly found in the myocardium but can also be released from skeletal muscle. It is used in diagnosing reinfarction for an acute MI because levels return to normal after 48 hours. So what happens is that when there is elevation of cardiac drop I, it remains elevated for up to 7 days. But when there is elevation of the CKMB, it returns to normal baseline levels after 2 days. So if there is reinfarction at the third day or the fourth day or the fifth day and so on, that probe I was still elevated in the first infarction. However, CKMB, which would have dropped to baseline, will now be elevated at third day, fourth day, fifth day, and so on. So this gives us a clue that there is a possibility of reinfarction, and therefore CKMB is considered more diagnostic in recurrent myocardial infarction than drop I. So the larger MIs can lead to better elevations in the drop I and CKMB. The ECG changes can include ST elevation, that is the STMI, which represents the transmural infarction of infarction of the entire wall of the myocardium. And the NSTMI represents the submyocardial infarction, that is an infarction that is present on the inner surface of the tissue only. There may be hyperacute T waves, that is the peak T waves. There may be T wave induction, there may be new left bundle branch flow. The pathologic Q waves or poor R waves provocation are the late findings of myocardial infarction.